My name is Richard Godfrey, CEO of BerGenBio, and it's my deep pleasure to welcome you to our reception this evening. I'm joined this evening by members of our executive team, also our principal investigators, scientific collaborators, and KOLs. This evening we're going to introduce you to AXL biology and some of the groundbreaking work we're doing in understanding how inhibiting AXL can help patients with aggressive cancers and other diseases. We have a broad phase 2 program working with bemcentinib, our first-in-class AXL inhibitor, and collectively presentations around the room will introduce these studies and some of the data to date. Thank you for your attention. Enjoy the presentations.
So I'm the warm-up back for the remainder of the PIs that'll be presenting the clinical trial results that we have to date. But I wanted to just give you a quick overview of the poster that is on this section, which represents our thinking about the role of the AXL receptor tyrosine kinase in cancer. And so we've been working on AXL for many years in my lab and around the world. And one of the most remarkable aspects of AXL is that it's invariably correlated with poor overall survival in cancer patients across a whole number of different solid malignancies and myeloid leukemias. And we and others have been trying to understand the basis for that. And a consensus is at this stage is that AXL is an important regulator of two key compartments in tumors. Shown on the upper right here in green is the role of AXL in regulating the innate immune response to tumors, and on the right is shows the role of AXL in regulating survival programs in tumor cells. And it's actually this understanding that's led us then to translate that understanding into the clinic. So on the left side, you'll see that AXL is associated with a immune suppressed microenvironment, in particular in macrophages and NK cells and also some dendritic cells. And its role in general is to suppress the immune response. It also, on the right, will regulate so-called tumor plasticity related to, for example, epithelial to mesenchymal transition. And it's actually this crosstalk which we think is very important in driving tumor drug resistance and immune evasion. The AXL receptor tyrosine kinase has a single ligand, Gas6, which you'll hear probably more about in the posters. In general, though, the role of AXL in normal physiology is limited. It's an important regulator of inflammatory diseases, as we'll hear from Dr. Hogebom. We're now able to measure the expression of AXL in tumors using new IHC methodologies. And what we can see is that, for example, on the bottom in this non-small cell lung cancer section is expression of AXL both in the tumor cells but also in, for example, adjacent alveolar macrophages. So in targeting these two compartments, as shown by our colleagues from UT Southwestern, Dr. Rolf Brecken, and he has a poster here, can take you through that. We see that we can derive benefits from selective inhibition of AXL, which you'll hear more about. Thank you very much.
I'm Matthew Krebs. I'm an investigator at the Christie Hospital in Manchester in the UK. So first of all, thanks very much, BerGenBio, for the opportunity to be here. It's a massive pleasure to be involved in this program, and a great pleasure to be able to present this poster on behalf of all the investigators involved. So I'm presenting to you the bemcentinib plus pembrolizumab in non-small cell lung cancer. This is for patients in the second-line setting, post-platinum-based chemotherapy. It could be for patients who are either positive or negative for PD-L1, so it's quite nice to recruit to. We know the landscape of lung cancer treatment is changing, but at the time this was recruiting, it was quite nice to be able to recruit patients who are PD-L1 negative. And also it didn't matter if they were AXL positive or negative, so we could look at that retrospectively. All patients needed to have a fresh tumor biopsy, so we could see the updated status of PD-L1 and AXL at the time to go on to chemotherapy. We know that AXL can become upregulated as a resistance mechanism to chemotherapy or to tyrosine kinase inhibitors. So really important we got that biopsy before they went on the study, so we could see what had changed in the AXL expression compared with the original diagnosis. I won't tell you too much. We encourage you to come along to the poster and ask questions. I just have to give you a little teaser. But there have been 22 patients recruited so far. Currently, the study is, as planned, will be on hold, so we can see the outcome from those patients before we recruit the next batch of patients in the next stage. We've got a response rate of around about 20% as an all-comers. And if you look at the PD-L1 negative patients, the response rate seems to be a bit higher, albeit it's small numbers of patients so far. We've got a nice case study on here. We've got some nice PD data from soluble circulating biomarkers. So I'd encourage you to come along and have a look at the data. Thanks.
Good afternoon, everyone. Thank you for coming. My name is Oddbjørn Straume. I work at the Haukeland University Hospital in Bergen in Norway. So what I have brought with me today to present to you is an investigator-initiated trial with bemcentinib in combination with standard of care treatment for melanoma, that is immunotherapy or MAP kinase inhibition with dabrafenib and trametinib. So if you come and visit me at the poster, I'll go through the design of the trial because it's a little bit complicated, but it's not that bad, and I'll show you some early response data and some CT scans, and we'll also be able to discuss our biomarker program that we are very proud of. We have a very broad biomarker program. We aim to find predictive markers for response to these combinations. So the trial is hypothesis generated. It's based on the research done by Jim Lawrence and his group. And it's very early data. We started including patients only 1 year ago. So it's too early to say anything very conclusive, but I can show you some details about the trial and what to expect from this trial and what we can use this trial for in the coming years. So, thank you.
So I'm David Gerber. I'm a professor at the University of Texas Harold C. Simmons Southwestern Cancer Center. And today I'll be discussing our phase 1 trial combining bemcentinib, the BerGenBio AXL inhibitor, with docetaxel chemotherapy for previously treated advanced non-small cell lung cancer. And just by way of background, while immunotherapy and targeted therapies have seen a lot of attention and enthusiasm in recent years for this disease, the reality is that almost universally our patients progress on both of those therapies and require treatment with chemotherapy. And the main chemotherapy drug that would be used at that point is a drug called docetaxel. It's given intravenously every 3 weeks. It's approved for previously treated metastatic non-small cell lung cancer, and its response rate in this disease is generally less than 10%. So that is, fewer than 10% of patients actually achieve meaningful tumor shrinkage with this approach. Why combine bemcentinib with docetaxel? There's preclinical data showing that of all of the classes of therapies that may enhance the effect of that class of chemotherapy, AXL inhibitors are at the top of the list, with some preclinical studies showing a 1,000-fold increase in preclinical efficacy. The way we designed this trial was with a staggered initiation. Patients come on study after their prior treatment, and they receive a week of bemcentinib before starting the docetaxel. This design allows us to accomplish 2 things. First of all, we know that during the loading period, the first 3 days when there's a higher dose, that patients are more likely to have toxicity from bemcentinib. By having the chemo start after that period, we lessen the combined toxicity. But equally important, with a staggered initiation, we're allowed to determine the pharmacodynamic effects of each drug alone and in combination. And what we've seen so far is promising. I will tell you this treatment is not without toxicity. We have seen some decrease in white blood cell count. But when you look at the efficacy, and I know it's too early to draw conclusions, instead of seeing fewer than 10% of patients respond, of the first 7 that we've been able to evaluate for tumor size after starting, 3 of them have formally responded. Now, we can't draw conclusions, as I've said, but this is a very promising avenue for us. And if we continue to see a trend like this in this early trial, I would certainly be encouraged to consider moving this forward into a larger randomized study in the future. What have we learned about the biomarkers? Well, the biomarkers take 2 forms. There are some tests that we look at after we start the drug, and when we see changes in protein in the blood after starting bemcetinib, some of those changes, such as increased thrombospondin, mirror the changes that we saw in the preclinical studies, showing us that we're having a similar biologic or physiologic effect. Have we identified any tests or biomarkers that we can look at before starting that might help us decide who's most likely to benefit from this combination? Again, it's very early, but as you can see from this figure, for this particular blood-based biomarker, levels certainly appear to be different in those patients who are going to respond compared to those patients who aren't. This is an example showing you just how long a patient can have response. We've had patients on the trial now for more than 6 months. One of our patients, unfortunately, had to stop treatment for several weeks. He did so not because of toxicity or progression, but because of logistical issues, and during that time he could not come to our center for treatment. During that time, the tumor grew. He, again, was able to come back to UT Southwestern after almost 2 months. We started him again on combination therapy, and it again shrank the cancer. So we're very excited about this combination, and I'd be happy to answer any questions.
Richard, thank you very much for the invitation to be here. It's a very big pleasure for me because I've been following the role of Axel in acute myeloid leukemia now for some years, and it's very rewarding to now be the investigator on the BGBC003 trial, and we have just completed the phase 1 part of the trial in which we treated 35 relapsed refractory elderly, non-eligible for intensive chemotherapy, acute myeloid leukemia patients, and also high-risk MDS patients. And I'm very happy to say that the drug was very well tolerated. And this was a very elderly, heavily pretreated population with a mean age about 74 years. And I'm very happy that we observed very good tolerability, so we did not see any grade 4 side effects. And we saw some responses, so the response rate in AML was 23% and in MDS 43%. And now I'm very excited that we also discovered a potential biomarker. Of course, the numbers are still small, but what we see is that if we stratify patients according to the biomarker, we can double the response rate in acute myeloid leukemia, meaning that patients expressing low levels of the biomarker have a much higher chance to respond. And this also fits with the biology. And then second, I'm quite convinced that the GAR6 axis plays a very important role, especially in the bone marrow, where it also inhibits anti-AML immune responses. And yeah, we are also following this up further. So if you have any questions relating to the trial, then just pass by the poster. And yeah, thank you very much.
I'll begin by thanking BerGenBio for the opportunity to come and speak here tonight. It's certainly a pleasure to be standing in front of a group of oncologists talking about a relatively rare disease, but some of you may have encountered it, and I'm going to tell you about some of the data we've been generating of late around acyl gas-6 TAM receptor biology in the context of idiopathic pulmonary fibrosis. So I've been given a little bit of time here to explain what the disease is before launching into the data. So very briefly, IPF is a chronic, irreversible, and incurable lung disease. It starts with scarring or stiffening of the alveolar lung tissue that impairs oxygen exchange. We're not advancing anymore. There we go. So IPF sufferers feel like they're actually breathing through a coffee stir. IPF kills the same number of people every year as breast cancer, but has a lower 5-year survival rate. And in fact, if we look at some rather dated data at this point, the 5-year survival rate here for IPF is certainly much worse than many of the cancers that are shown here. Now, just to put this into some context, if we were to consider IPF versus a much more common pulmonary disease, that being chronic obstructive pulmonary disease, IPF is really like COPD's bigger and deadlier brother, in that if COPD is an elephant on your chest, then IPF is really the entire herd. It is considered an orphan drug indication, and really based upon narrow estimates, the US prevalence is between 14 to 63 cases per 100,000 population, which translates into upwards of 90,000 IPF patients. And there's an incidence of about 50,000 new cases a year. Other estimates peg it at the prevalence being slightly higher, close to 200,000 cases, but either using this narrow or broad estimate approach, you can see that it's certainly an orphan drug indication. It mostly affects the elderly, and it's heterogeneous in its presentation. It's certainly idiopathic in that we don't know the risk factors, or we don't know what's causing IPF, but risk factors are thought to include smoking, environmental exposures, chronic viral infections. Many, if not all of these patients show abnormal acid reflux, and there are patients that show a family history of this disease, which we refer to as familial IPF. Now, the patient profile is as such. The male to female ratio is about 1.5 to 1. The age of presentation is typically in the 6th decade of life. And there is usually a fairly prominent smoking history, upwards of 70%. Some other key features to bring to the forefront is that this disease is unpredictable in its course. Diagnosis still remains a big challenge, requiring the efforts of radiologists, pathologists, as well as pulmonologists. And these patients do suffer from comorbidities, including COPD and pulmonary hypertension. We don't really know what's driving the progression in this disease, and this has been a major question in my laboratory over the years. But in approximately 50% of these patients, death is seen within 2 to 3 years of diagnosis, and this is in part due to the lung becoming stiff and shrinking, thereby leading to the ability of these patients to breathe, and physiologic measurements, including forced vital capacity, bear out the severe problem that these patients are having in breathing. So this 50% mortality rate after diagnosis is seen within 2 to 3 years. Now, if we look at estimated deaths from various chronic respiratory diseases in the US now, we note that all chronic respiratory diseases appear to have maxed recently and are sort of on a downward trajectory. This is in part because of the signal seen in chronic obstructive pulmonary disease. But if we look at interstitial diseases and include other rare diseases, including pulmonary sarcoidosis, the trend seems to be continuing upward. Now, prior to 2014, the IPF treatment landscape was rather bleak. The listing of drugs that have been tried included corticosteroids, various types of immunosuppressants, as well as N-acetylcysteine. As you can see, there was minimal, if any, impact on disease progression, mostly symptomatic relief, but certainly nothing that provided any benefit in terms of slowing the progression of this disease. And that all changed, though, in the fall of 2014 when pirfenidone was approved here in the United States by the FDA. And this drug then was shown to not only reduce mortality, but also had a major effect on forced vital capacity. So what we note here is that there was a 47% reduction in the proportion of patients with a decline in FVC on drug versus the placebo control group. Now, the adverse events that patients on pirfenidone complained about were largely in two categories, one being GI, involving nausea, and the other being a skin rash. Now, also that year, the FDA approved another drug. It's also used in oncology. Many of you may know of this drug. It's an nintedanib. It's a intracellular inhibitor of multiple tyrosine kinases, although they describe it as an angiokinase inhibitor. Many, if not all, of the secondary endpoints were not achieved, but there was an effect on mortality and a more modest improvement in forced vital capacity in the group that received nintedanib versus placebo control. Adverse events included many GI problems, including diarrhea. So since the launch of these two drugs in the United States, the IPF market now approaches nearly $1.5 billion, and that exceeded analysts' expectations by over $700 million. And certainly you can see that the sales of approved IPF drugs are expected to move upward, approaching $2.5 billion by 2020, if not sooner. Now, the major question might be, is there any more space for therapeutics in this disease? And what I need to do is backtrack a little bit here and explain how patients are typically stratified into three categories based upon forced vital capacity. So the IPF patient segmentation is briefly summarized here, but patients fall into this mild category when their forced vital capacity is relatively mild, in that there is a very mild defect in FVC. They fall into the moderate or the severe categories, again, based upon forced vital capacity characterization, in that percent predicted can fall below even 24% in those patients that show very severe disease. It's important to keep that in mind when we consider that it's really the moderate to severe IPF patients that need therapeutic options, in that nintedanib and pirfenidone show effects in the clinical trials and in ongoing studies of these drugs in patients with mild and a certain proportion of the moderate patients with IPF. So the way we interpret this is that there is a significant unmet medical need, and this might represent upwards of perhaps 50% of IPF patients. So enter Gas6 TAM receptors and the importance of this pathway in IPF. And I'm showing you some unpublished data from a study at the University of Michigan while I was there in 2011, in which we looked at transcript levels for AXL in peripheral blood samples from IPF patients. And there were some very interesting trends here in terms of the AXL high group showing increased mortality, and also the inverse relationship between Gas6 expression and Tyro3 expression with respect to lung physiology parameters, including forced vital capacity and diffusing coefficient of carbon monoxide. Just recently, we have published many of these data in the American Journal of Respiratory and Critical Care Medicine, but I just want to point out some of the highlights from our study around the exploration of Gas6 and AXL in the fibrotic mechanisms driving idiopathic pulmonary fibrosis, and in particular those patients that show this moderate to severe phenotype. So when we looked at Gas6 AXL transcript in activated protein expression in IPF lungs, we noted that there was certainly a group of patients that showed tremendously high transcript levels of both Gas6 and AXL. And note that this is a log 10 scale that I'm showing you here. Now, when we explored diagnostic biopsies from the patients outlined in red, it was immediately evident to us that there was a very strong protein signature for AXL and Tyro3, but not for MERTK. And indeed, when we looked more closely and quantified P-AXL expression, again in these patients with severe IPF, in this case based on how quickly they progressed in disease, again we saw that there was a significant increase, marked expression of phosphorylated AXL in these patients with severe IPF. Now, our strategy at that point was a multi-pronged one in which we utilized both in vitro as well as in vivo studies and employed biologic small molecule inhibitors as well as the multi-kinase receptor inhibitor, nintedanib, also known as BIVF 1120. And really our approach here was to look at both IPF and normal fibroblasts that have been isolated from patients with this disease and explore the biology of these cells when we're manipulating the Gas6 AXL or multiple tyrosine kinase receptors. I'll also briefly touch on and show you some data from in vivo studies that give us a clue as to how IPF fibroblasts might be driving disease. And this is done in the context of immunodeficient mice. And then finally, I'll show you data from a bleomycin-induced pulmonary fibrosis model. I also need to point out that throughout this study, I'll interchange these designators, R428, BGB324, and bemcitinib. Clearly, these are all synonyms of the same compound. Now, first and most striking to us was that the small molecule inhibitors of the TAM receptors, rather than the biologics that we had in hand, were most effective at modulating IPF fibroblast activation. And this was noted in the context of TGF-beta stimulation, looking at collagen generation by IPF as well as normal fibroblasts stimulated with TGF-beta in vitro. We also noted that with extended treatment that is extending for a couple weeks in vitro, we noted that we were able to attenuate many of the matrix components generated by these fibroblasts, whereas the biologic in this case had no effect. And then finally, and most exciting for us, was the fact that targeting AXL with a small molecule approach in BGB324 substantially inhibited the activation of fibroblast progenitors. So these SSE4 expressing cells are the cells that give rise to the pathogenic fibroblasts that we detect in these patients. So R428 or BGB324, but not this biologic S6, reduced transcript expression of profibrotic genes and the numbers of SSE4 positive cells. So the ability of a therapeutic to target the synthetic properties of these cells is interesting, but really from the standpoint of what distinguishes severe from more mild or moderate disease, there is an aspect of fibroblast behavior that is now just becoming of interest, and that is the invasive properties of these cells. And the way we explore that is through the use of a fibroblast functional assay. Many in the room will be very familiar with this process of looking at the invasive properties of tumor cells when they're in a mesenchymal state. But this assay really provides us then with the ability to monitor in a very specific manner the ability of our various approaches, whether they be biologic or small molecule, to attenuate the ability of both normal and IPF fibroblasts to invade in tissues. So in this case, we're looking at the relative wound density as a percentage. And you'll note that R428 was very effective in inhibiting the ability of these pathologic fibroblasts to invade through matrix, whereas the biologics had no effect. I'll just quickly move on to the in vivo data. In this case, I'll just show you the data from a Gas6 deficient mouse challenged with bleomycin versus its wild-type counterparts. At the day 14 time point where we conducted this analysis, we noted that AXL, MERTK, and Gas6 are increased at the transcript level. But more importantly, with the absence of Gas6 in this mouse model following bleomycin challenge, there was a significant reduction in a biochemical measure of fibrosis, and that being hydroxyproline. Now, a model that we developed a number of years ago, and also a model that would certainly be very familiar to all the oncologists in the room, and that is the employment of these human cells to humanize immunodeficient or SCID mice. And in this context, we've noted that the introduction of IPF fibroblasts, but not normal lung fibroblasts, leads to a reproducible and maintained fibrotic response in these mice. So once these cells are infused into the mouse, they distribute to various organs, as one can imagine after an intravenous injection, and yet it's only in the lung that we know these cells driving any kind of a fibrotic process. So in this in vivo study, after the cells were injected, we began treatment with the TAM receptor inhibitors or with nintedanib or BIVF 1120. And our analysis then was at day 35. So why would we focus on day 35? Well, it was really at that time point where we saw the increases in both Gas6 and AXL at the transcript level. It did show up a little bit earlier at day 21, but the fibrosis was most evident at that day 35 time point. Targeting with these inhibitors then altered the expression of a number of markers of fibrosis, including hydroxyproline and platelet-derived growth factor receptor beta. And we also noted that targeting AXL with R428 significantly reduced the phosphorylation of AXL and did have an effect on TYRO3. And then finally, from this in vivo study, I'll just highlight that we noted that targeting with the small molecule approach and not with BIVF led to an attenuation in the fibrosis in these humanized mouse lungs. So I'll quickly summarize, and I appreciate your patience as you've allowed me to go through these data. Clearly this is a new area of investigation for us, and we're very excited with the data we have around the expression of Gas6 AXL, the phosphorylated version of AXL, as well as TYRO3, particularly in this subset of IPF patients for which we don't have adequate treatments now, namely the severe IPF patients. So targeting TAM receptors with bemcentinib abolished both synthetic as well as the functional properties of these primary lung fibroblasts in vitro assays. And then more importantly, we've extended this now in vivo with the targeting of Gas6 and TAM to show that we're able to ameliorate fibrotic processes in an in vivo model of IPF. Just briefly thank members of my lab, including David, Milena, Ana Lucia, and Miriam for their help in generating these data and moving this project forward. And finally, the funding sources from the NIH as well as from Cedars-Sinai, where I'm situated now, University of Michigan, where I was located for a number of years, as well as BerGenBio. So again, thank you for your patience, and I'll be more than happy to answer any questions for you. Thank you.